four parathyroid glands. They're about the size of a grain of rice, and they're located on the posterior aspect of the thyroid. So there's two on each side, one on the upper left and upper right lobes, and one on the lower left and one on the lower right lobe. They secrete a hormone called parathyroid hormone, which aids in plasma calcium regulation. So what happens is PTH will liberate calcium from bone and increase plasma calcium. Now there's an opposite hormone called calcitonin, which takes calcium from the blood and deposits it into the bone. Remember from all your biology classes that bone is actually living tissue. It's not dead, and it's constantly undergoing what we call remodeling. That happens as a result of these cells called osteoclasts, which break down bone, and osteoblasts, which build new bone. So this remodeling is always occurring, and that remodeling is governed by these hormones, parathyroid hormone and calcitonin. Now, the parathyroid glands will sometimes become cancerous and have to be removed. Often, they will try to spare whatever parathyroids they can. So even if they're taking out an entire thyroid, they try to remove at least one of the parathyroids and just explant it into the tissue. And the patient will usually do quite well. So if you have hyperparathyroidism, you will see an elevated serum calcium, which means more is coming from the bone, and so that can result in osteoporosis. Hypoparathyroidism is more rare, but it leads to a lower serum calcium. And as I mentioned again, they'll explant the parathyroids in the surrounding tissue. They will continue to function and often mitigate the need for having to take replacement therapy. And here they are. There's a posterior aspect of the thyroid, and here's your four parathyroids. Okay, so that's the RLN, that's your thyroid, that's your vocal cords. It's not a lot of anatomy. I'm trying to keep this very relevant to what we do on a day-to-day basis. So everything that I just went over is fairly important. So I'd like you to know, the details of the anatomy. I'd like to now go into the anatomy of the facial nerve and the facial musculature. So in this figure, you see the different facial muscles, and what you see is the facial nerve coming out of the skull and entering into what I'm going to tell you in a minute, the parotid, and then beginning to branch. Remember that the facial nerve innervates all of the muscles of facial expression. So anything you can do with your face, any muscle that helps you express yourself with your face, is innervated by the facial nerve. Remember, the trigeminal nerve, cranial nerve 5, innervates the muscles of mastication. That is actually the temporalis and the masseter. Okay. Now there's some facial nerve innervation in the temporalis as well, but masseter muscle. Just go ahead and start chewing and feel what muscles are working, and you'll feel the temporalis and you'll feel your masseter. That's how you identify masseter. If you need to monitor it, you go into pre-op, you ask the patient to bite down, and you get a skin marker, and you mark exactly where the contracted muscle is. That's your masseter. Here are the muscles of the face. Occipitofrontalis, we usually just call frontalis, and then in the back we call it occipitalis. The orbicularis oculi, the ring muscle surrounding the eye. Now we will monitor this muscle. Very important when you place your needles here that you make sure that you feel that you're along the superior orbital ridge. Pretty much stay near the eyebrow. You don't want to end up sticking into the orbit. So we want to be really careful about that. It's not hard, but something I want to point out to you. Levator labiae superioris. All of these muscles get their name based on their location or their actions. In this case, levator, lifter, labii, lips, superioris, superior, lifter of the upper lip. Then we have the zygomaticus, major and minor, risorius. Look at this one, levator, anguli, oris, lifter of the corner of the mouth. And then its antagonistic muscle is the depressor anguli oris. Depressor labii inferioris. Okay, so that's antagonistic for superioris up here. Here's your orbicularis oris. Your buccinator muscle, Here's your masseter, big meaty muscle, right? Again, that's a power muscle. If you're chewing, that's innervated by cranial nerve 5 or the trigeminal. Remember that the trigeminal nerve is mainly sensory to the face, right? It has 3 branches, V1, V2, V3. We'll talk about this in the crani course, but that it is motor to those 2 muscle groups. Nasalis, this is one that we monitor right here. Mentalis, we monitor that. And here's platysma. This is a big sheet muscle. When you get old, that's what gives you a double chin. It's weak. We don't generally monitor this. This is innervated by the 5th branch of the facial nerve, the cervical branch, and generally we do not monitor it, although we can if we're asked to. Here are the branches of the facial nerve: Tell, Ziggy, Bob, Marley, Column. That's temporal, zygomatic, buccal, marginal mandibular, and cervical. Now, if we're monitoring a parotidectomy, we're going to monitor 4 out of these 5 branches. Because the parotid actually, when it leaves the skull, the facial nerve, when it leaves the skull, enters the parotid gland, and then it divides into the 5 branches. So we're going to want to monitor all 5 of these individual branches. If we're doing intracranial work, we're doing a posterior fossa case, and we'll talk more about this in craniotomy, but we won't need to monitor all of these branches. Generally, we'll pick 2. Now, one of the most important branches to pick is the marginal mandibular. So you should always be monitoring marginal mandibular. The reason is, topographically within the nerve, the fibers that contribute to this branch are superficial in the nerve. So if you just nick the nerve, you're most likely to hit fibers that are going to contribute to the marginal mandibular. Right? So it's the most important to monitor. In a parotid, we're going to monitor all 4 out of 5. The muscles that we use to monitor the facial nerve would be for the and this is a great figure. You should look at this because it'll show you that there's more than one way to skin a cat. The temporal branch, either frontalis or orbicularis oculi. All right. I usually stick my needles right around here and here, somewhere in here. Zygomatic branch, either of the zygomaticus, levator labii superioris, or levator labii superioris aliquot nasi. It's a small muscle. It lifts the upper lip and also lifts the alar of the nose. Okay. One that's not mentioned here, but that we use is the nasalis. So for zygomatic, I go right here into nasalis. Okay, but any of these are acceptable. The buccal branch, either the buccinator or O oris. I generally do O oris. And then marginal mandibular. Any of these are acceptable. I usually do the mentalis. All right, but you have some choices here. And there is some cross coverage. So just like when we're doing our spinal myotomes, you want to be aware of that. Here's a photograph in situ showing the branching of the facial nerve and a big old parotid tumor. Now, it says deep lobe tumor. The anatomy of the parotid is such that it's all one gland, but the facial nerve goes right through the middle of it, and it branches. So anything that is superficial to the plane of the nerve, we call it the superficial lobe. And anything deep to the facial nerve, we call it the deep lobe. So sometimes we'll do a total parotidectomy where they need to take both superficial and deep, and sometimes they'll just do a superficial. Those are a lot easier because they dissect down to the plane of the nerve, they remove that tissue, and they leave the rest. Most of the time, these are totals, though. Interestingly, too, if I forget to mention, the facial nerve is awesome because it's motor, it's somatic motor, voluntary movement to muscles of facial expression, but it does all sort of other things, too. It's viscerosensory. It provides taste sensation to the anterior 2/3 of the tongue. Now, what provides taste sensation to the posterior 1/3? The answer would be cranial nerve number 9, glossopharyngeal. I want you to know that, although we'll talk about it more in craniotomy. It's also parasympathetic. It innervates the lacrimal gland for tear production. It innervates, get this, all of the salivary glands except the parotid, the one that goes right through. It doesn't bother to stop and innervate the parotid. It just goes right through. Here's a pathology I want you to know called Bell's palsy. It's an idiopathic condition that results in a unilateral facial paralysis. Idiopathic, if you remember, means that there's no known cause. All right, it's not secondary to some major pathology. We treat it with steroids. Oftentimes it's untreated and it will generally resolve. A stress or a trauma, this is commonly childbirth or extreme temperatures, are known to bring on Bell's palsy.